Hi, my name is Christopher Meduri. I'm an interventional cardiologist at the Karolinska University Hospital in Stockholm, Sweden. I previously worked in the United States and there served as a national primary investigator on multiple transcatheter valve therapy trials. I am passionate and interested in providing novel therapies to patients with valvular heart disease. And in my time trained at practice, I performed over 1,700 TAVR procedures. Current TAVRs really were designed as an alternative to open heart surgery. But I think as we're looking now to lower risk patients and younger patients, we really have to be focusing on what designs are important to really optimize care for the lifetime management of patients with severe aortic stenosis. And, to the credit of the prior TAVR devices, there were important iterations that needed to happen, such as better sealing skirts to reduce PVL and modifications to reduce pacemaker rates. But now, when we talk about lower patients and lifetime management, we have to really focus on other things. One of these things is really looking at focusing on really near normal or as close to normal hemodynamic restoration, because these patients are more active and they anticipate having a much longer life ahead of them. Additionally, we want to be able to provide significant reassurances that durability may last the lifetime of the patient. Right now, I think that we are still more in a range of what we expect with a surgical aortic valve replacement, which is tissue-based. And so to think of treating a 60 or 65-year-old patient, we want to be looking at offering near duration or durability of something we'd see with mechanical prostheses. And additionally, when we treat these patients, we need to be thinking that if, in the unfortunate scenario that something does break down, we do need to do a repeat intervention, that we have actually left these patients in a position that we can easily perform a reintervention based off of the characteristics of their first TAVR procedure. I believe that a 3D single piece aortic valve leaflet design is really the potentially transformative technology to allow us to not just evolve, but really revolutionize TAVR. And that's because what we can accomplish with a 3D shaped tissue technology is that we can achieve superior annular hemodynamics with a balloon expandable technology, i.e. we're not limited by an extremely high stent height, but this prior shaping allows us to have near typical balloon expandable height with superior hemodynamics. And so I think this is going to be critically important because now this allows us to facilitate easily reintervention while again obtaining superior hemodynamics. Durability is really impacted by both tissue science as well as valve design. And it's the tissue science that allows us to really improve durability by, with this technology, completely removing any remnants of DNA or RNA so that we minimize or really take away any potential immunogenic response. And additionally, we're able to remove any trace of glutaraldehyde, eradicating any cytogenic potential response. And we believe that these two things in combination provide the lowest likelihood of calcification of these tissues. Additionally, that combined with improvements in valve design that really impact the biomechanical attributes such as leaflet stress and not having as good of coaptation, work in combination to reduce calcification and really prevent further or long-term structural valve degeneration. I believe there is a valve that has a potential not just to evolve the TAVR space, but really revolutionize the TAVR space. And that's the DurAVR system. And that's because we can offer this balloon expandable system with a supraannular function, which really allows us to, again, offer ease of use with superior hemodynamics and really optimize lifetime potential management if there was to be an issue. Additionally, it has superior anti-calcification treatment with the ADAPT technology that we believe will allow this valve to last longer. And its unique design, again, with the 3D piece tissue, will allow likely close to near normal hemodynamics after performing the TAVR. And I believe this will allow us to consider treatment one time only for all potential TAVR patients. Thank you everybody for watching this, and I hope you have a good time participating in London Valves.